good you are at everything else. This is the prerequisite. And by that, it's the most important thing we do. You will not find a patient who's not anxious about this, so make sure you get this one.
Thank you, Nat. Great presentation, Kendall. So thank you guys all for coming. Again, nails don't always fill the room, but it's great to see everyone here excited. This is definitely, as a Mohs surgeon, a really important part of my practice, my medical and surgical nail clinic. No disclosures here. So I'm going to be talking about a technique for nail unit anesthesia, which I have found to be reproducible, successful every time for my patients. So there are, of course, many other ways to anesthetize a digit. So this is actually a comprehensive review of nail unit anesthesia that Nat published over 10 years ago. It still holds up, so if you want more information, I would recommend that you reference that paper. So why is nail unit anesthesia important? So it's just like Nat said, right? These patients come in with high levels of anxiety surrounding nail unit procedures. And I think any of us who've done a nail unit procedure know that level of anxiety is higher than pretty much any other procedure we do on the skin, right? Patients will have genital biopsies and they would rather do that than their nails. I've had plenty of patients who have said that. And when we've actually looked in the hand and the foot and the dermatology literature, this is upheld through multiple studies. So we really have to respect their anxiety and really strive to give excellent anesthesia every single time. So what is the anatomy? What are we targeting here? Well, if we are looking at our digit, right, we have these paired dorsal and volar nerves. The long fingers, so we're going to call this our 2, 3, and 4, are innervated primarily by that volar branch that just past the DIP joint. That's going to branch and give sensation to the entirety of the nail unit. And then our thumb and our pinky actually have the that dorsal branch contributes. So for our thumb and our pinky, we have to be thinking about both of those different nerve units. So again, looking at our long fingers, if this is where we are going to be anesthetizing, we're really thinking about that volar nerve. And then if we're thinking about our thumb and our pinky, we're going to be thinking about the dorsal and the volar nerves in our procedure. Anesthetic choice, this is important for all of our cutaneous surgeries. And when we are picking out our anesthetic, we're thinking about our onset of action. How rapidly are these going to work? Is there vasoconstriction in your anesthetic, and do you want that? And then, of course, the duration of action. How long does this last, and how does that optimize your patient's experience? So if we're putting all these things together, we can actually turn our attention to a really nice study looking at ropivacaine versus lidocaine in digital blocks. And what this study looked at was, again, onset of action, right? So the difference in onset between lidocaine and ropivacaine, it's not very much, right? But ropivacaine takes a little bit longer. But duration of action, this is the really important thing here. So duration of effect of ropivacaine can be almost a full day, right? Versus lidocaine, which is a few hours. Now, if we catalog this information and then we look at a study published by our colleague Dr. Lipner looking at pain after nail surgery, what we find is postoperative pain is going to be highest in the first 6 to 12 hours. And every patient is going to say, okay, fine, you're going to numb my finger, it's not going to hurt now, but how's it going to feel later today? So if you're imagining, you can counsel them as to when they're going to have the most post-op pain. And then when they've looked at ropivacaine in nail blocks, we found they need less post-operative analgesia. So this is something you can tell your patient, we can give you an anesthetic that has a long duration of action such that you shouldn't feel pain for the first 24 hours. And in that place, you can then counsel them on using their acetaminophen, their ibuprofen, elevating and immobilizing that digit to really optimize postoperative pain. So in our clinics, we almost exclusively use ropivacaine for our digital blocks, and the 1% is going to be more effective with the longer duration than the lesser concentrations. And also, what's nice about ropivacaine is it does have some inherent vasoconstriction. So you get more of that hemostasis with ropivacaine, as well as the bonus of a longer duration of action. Now, what about epinephrine? Well, what we found, if you do a literature review, and this is merely 2 papers of which there are myriad on PubMed, is that there's not data which suggests that epinephrine is unsafe in digital blocks. So we can use epinephrine in our digital blocks very safely, of course, keeping in mind certain contraindications such that you would want to avoid epinephrine. But say you don't have ropivacaine in your clinic, or you're not comfortable using it and you want to use lidocaine, you'd like some vasoconstriction, you can know that the data supports safely using lidocaine with epi. Now we think about pain, right? Pain starts at home for these patients. You know they're coming in with high levels of anxiety, and I'm just going to show a short clip illustrating this point.
Construction worker jumps off a scaffolding onto a nail. The nail goes completely through his boot. He starts screaming in pain. They rush him to the hospital. They give him IV pain medication when he gets there. And they take his boot off, and the nail is right between his toes. Is his pain real? Yes, because all pain is real. All pain is created by his brain. And his brain predicted that he should have pain based on the nail. But that's how our brain works. So the pain that occurs due to a fracture is exactly the same as the pain that occurs due to a stressful situation that occurs in our life. The most important thing is that it's not all in your head. When a doctor says, or anybody says it's all in your head, it's cruel.
Yeah.
And it's ignorant because it implies that it's their fault, or making it up. Never underestimate the power of the brain to create severe pain, severe fatigue. It's amazing. But it's true, we see it every day. Construction worker jumps off a...
So to this point, right, this is the idea of the nocebo effect, and we see that very strongly in our nail patients. If you are expecting a negative stimulus, you are going to have a negative experience. And so we as physicians need to come to these encounters fully aware of this nocebo effect and with plans in place to mitigate this. So this is a really nice paper I like that's in the anesthesia literature, looking at the nocebo effect in administration of local anesthesia. What's really helpful in this paper was this table helping us to rework our language. And one of my medical assistants actually printed this up and put it up in her exam room because your phrasing is really going to affect what that patient is expecting to feel. So we really try to adjust our phrasing around a procedure for which they already are carrying a very significant level of anxiety. And even this idea when a patient says they feel something and we minimize it by saying, are you sure you're not feeling pressure, right? All of these things are negating their experience, and we need to be really aware of this. Now, the discomfort that they, the physical pain that they're feeling from this anesthesia, this is twofold. This is from the needle insertion, right? So just getting a needle poked into our skin does hurt. And then the fluid infiltration. So our finger is a relatively small anatomic unit with stiff tissue. So the stiffer the tissue, the higher the resistance, the more pain they're going to feel. So we really want to think about these things as we're giving our blocks. And so we will use distracting stimuli. We use a refrigerant spray that you're spraying where you're injecting to help with that pinprick sensation. Sometimes you can use a vibratory device to take advantage of the gate control theory of pain. Injecting very slowly is super important, right, because of that tissue distension. And then talkesthesia, right? We're thinking about our nocebo effect. Our nail procedures, we're talking, we're making jokes, we're playing music, right? You really want to take them out of that experience. And this has been shown by some of our Italian colleagues to really impact, again, their experience overall. And what they found was positive communication with your physician in the room actually impacted not only the experience with the procedure, but their post-op pain, right? So we are building this whole experience, and I think with nail procedures, more than many, this is super, super important. So now let's talk about techniques, right? That's what we all are here to learn. A lot of different techniques for nail unit anesthesia. You can do infiltrative type wing blocks, or you can do full nerve blocks. And there are a lot of different, there are a few different techniques for nerve blocks. I'm really gonna dive into the digital block because this is something that, like I said, in my clinic, it is reproducible, it is successful, it is a relatively easy procedure to perform. Think about our digital block. We are back to our anatomy here, right? So a digital block can be proximal, or it can be digital, or distal, or it can be somewhere in between. So a distal digital block, if we're thinking about this, we are again targeting the volar innervation, and that nerve is going to branch just distal to the DIP joint. So this is the area where you want to inject your anesthetic. So we will be injecting perpendicular to the digit, just past the DIP joint. The benefit of a distal digital block is this is a very rapid onset. You can see you're injecting right where the innervation is. So if you're in a busy clinic, you'd like to get this procedure done as quickly as possible, this is a great procedure. And again, you are injecting, targeting that, those paired nerves. Now, this is our line of innervation, right? So if we think about our digital block and where we want to block, we can be injecting anywhere along this line, right? We can be fully proximal, we can be fully distal, or we can be somewhere in between. And over the past few years, my practice has really evolved. The purple circles, this is where I'm typically injecting. This is a sweet spot, right? We are, it's low resistance tissue, so pain of distension is not very much. And onset is fairly rapid, right? You don't have that far to travel. So by the time I inject this and then I go put on my sterile gloves, my patient is scrubbed and prepped, these patients are typically numb. So onset is fairly rapid and it is a fairly comfortable procedure. So this is just how we do it in our clinics. You can see here using that refrigerant spray, and then I am injecting into that space perpendicular to the nail unit, or to the digit. I'm injecting probably 0.5 to 1 cc's per side, looking for blanching to the mid-sagittal line. And then I'm massaging, and then I go to the other side, similar, perpendicular to the digit, injecting nice and slowly, looking for blanching, and then really massaging that fluid into that digit so it gets infuses into that nerve. And then again, letting them sit for a few minutes, as long as you want to, because if you're using something like ropivacaine, it gives you plenty of time. And these are reproducible, easy blocks to do. So putting it all together here, right, I think very important to honor the nocebo effect in their pre-procedural anxiety. Long-acting anesthetics can help twofold because of the postoperative pain. And then, of course, just practice, right? Pay attention to your blocks. You want to do it better and better every time. Thank you much.
Thank you, Julie.